For today's EMN5, I'd like to talk about EPSS and how you measure it on cardiac ultrasound. So what is EPSS? It stands for E-point septal separation, and it's a pretty simple measurement that we can do on cardiac echoes just right at the bedside in the ER that helps us measure ejection fraction or assess for CHF in a patient. Now, for those physicians that have a lot of ultrasound training or are cardiologists, it might be pretty easy for them to do the kind of eyeballing method where they look at an ultrasound, look at the contractility between diastole and systole, and decide if there's good LV function, such as in this ultrasound, or if there's poor LV contractility. Now, this one's pretty obvious. Even I can see that there's pretty poor LV contractility. However, what about those ones that are in between? Wouldn't it be helpful if there was some way to measure, for those of us that are not as good with echo, or maybe just learning, some measurement that we could do that could tell us what kind of EF we're looking at? Well, lucky for us, there is, and that's the EPSS that I want to talk about today. So let's talk about first what kind of echo we need to get in order to measure the EPSS. So it has to be a parasternal long view. So just left of the sternum at about the third or fourth intercostal space with the marker towards the patient's left hip. And this is the image that you should be able to get. We have the left ventricle over here, and this correlates down here, left ventricle. Left atrium is up here, left atrium. We have the right ventricle on this side with the septum in between here. And then we have our aortic arch is up here coming down into the aortic valve, and you should be able to see the mitral valve. So specifically, we need to identify the anterior leaflet of the mitral valve, and there's the posterior leaflet just as reference, and the septum. And the EPSS is going to be the measurement between the anterior leaflet and the LV septum. Now, obviously, that mitral valve is moving, and we're not going to try to measure it while it's moving. So instead, what we're going to do is measure it in M mode. So here again is our septum, and there's the anterior leaflet of the mitral valve. We're going to throw our M mode line right across there, right where the mitral valve is moving. And this is what we should get once we're recording. And again, just to correlate, there's our septum, and there's the mitral valve. So this is the mitral valve moving along. And that distance between where the mitral valve is closest to the septum, that's where we're going to measure our EPSS. Now, as you probably noticed, there's actually kind of two peaks to that line. That's called the E wave and then the A wave. Now, remember, this is E-point septal separation, meaning we're measuring the E wave. And you don't even have to remember E and A wave. All you're doing is measuring where the mitral valve gets closest to the septum. But just in case you're interested, what the waves stand for. The E wave, like we said, is the maximum point of mitral valve opening during the beginning of diastole. The A wave is the slightly smaller, it comes second after the E wave, and it represents the left atrial contraction. So now we've measured our EPSS. Well, what does that mean? If your EPSS is less than 7 millimeters, you have a normal EF. Now, as far as the cutoff for the low EF, I've seen a lot of numbers thrown out there in different papers. I've seen 10, I've seen 11, I've seen 12, and obviously the higher you get, the more sensitive that's going to be for a low EF. Overall, the consensus seems to be that if it's over 10 millimeters or 1 centimeter, that correlates to a low EF. So just remember, less than 7 is normal, somewhere in between 7 and 10 is probably a mild to moderate, and a low EF you can be pretty sure you're seeing if it's greater than 10 millimeters. So let's do a quick example. Here's an ultrasound I took just last month, and looking at the heart, it doesn't look like it has the greatest contractility, but let's get a good measurement here. So we're going to throw our M mode line across where that mitral valve tip comes up closest to the septum, and this was the result in the M mode. So then we measured the distance between the septum and the anterior portion of the mitral valve, and we got 1.5 centimeters or 15 millimeters. So here we have a good measurement that we can record that's reproducible that says this patient has a low EF and likely CHF. Now, when is this not valid? When there's any mitral valve abnormalities, obviously if there's stenosis, regurgitation, you're not going to see that mitral valve move in the same way. And so obviously you can't say that the EPSS is going to be an accurate measurement of LV contractility. Same thing if there's some aortic regurg or extreme LV hypertrophy. Now, the nice thing is this has been validated amongst junior emergency physicians, in this case it was residents, to try to see if they could actually measure it. And they compared their EPSS measurements against some emergency physicians that were ultrasound trained, as well as some cardiologists that were doing the kind of classic eyeballing, looking for EF and giving a percentage. And they saw that we did really well. So this is pretty validated. Go ahead and try it in the ER next time you have a patient that you're concerned about CHF. So let's review. EPSS, it's the distance between the anterior mitral valve leaflet and the alveoli septum. You're going to be doing this in parasternal long view, and make sure to use your M mode to measure it out. If you have an EPSS less than 7 millimeters, that is normal EF. And if you have it greater than 10 or 1 centimeter, you have a low EF. There's some references from the papers I mentioned, and these are a couple of blogs from our favorite ultrasound blogs that have some more discussion about EPSS. Thanks for joining us on EM in 5.